All right, everyone, we'll get started. Good morning. My name is Jocelyn Mesa. I'm an assistant professor in the psychiatry department, and it's my delight to be introducing our very own Gia Chodzen. She will be presenting today on the impact of contextual factors on diverse adolescents' ability to access, engage in, and benefit from psychosocial interventions. But before she gets started, I want to share a little bit about her amazing background and her training to date. Gia Chodzen is a doctoral candidate in the clinical psychology department at UCLA and a pre-doctoral clinical psychology intern in the general track within the UCLA Semel Institute for Neuroscience and Human Behavior. Her research focuses on examining how stressors related to structural inequality impact minority status adolescents' ability to access, engage in, and benefit from psychological treatment, particularly for PTSD. In addition, she is interested in how novel formats of psychological intervention delivery can be leveraged to improve widespread access to mental health care. Gia, welcome, and we're excited to hear what you have to say. And everyone, if you have questions, you can put them in the Q&A in the bottom, and I'll be keeping track of them and saving them for the end of the talk. Take it away, Gia.
All right, thank you so much for that lovely introduction. Let me go ahead and get my screen sharing ready to go. All right, so again, thank you so much for the introduction. I'm so thrilled to be sharing my research with you all. Today, I'll be talking about the impact of contextual factors on diverse adolescents' ability to access, engage in, and benefit from psychological interventions. And I don't have any disclosures, and I would like everybody to save their questions until the Q&A portion at the end. Thank you. So like Dr. Meza said, my name is Gia. I wanted to just tell you a little bit about me before I go into the presentation. So I am a psychology intern here at UCLA Health and Semel in the general child track. I'm also a clinical psychology doctoral candidate at UCLA, and I'll be finishing up my degree in just a couple of months in June. And the research that I'll be presenting today is actually part of my dissertation, so I'm excited to share that with you all. My research interests are in structural inequality, mental health systems, and brief interventions. And clinically, I'm really interested in child and adolescent psychology broadly, suicidality, and trauma. And I'm particularly interested in how we can consider issues related to structural inequality in care. The learning objectives of today's presentation are sort of threefold. So the first one is to answer how does neighborhood level inequality impact whether adolescents access mental health care? The next is how do chronic structural stressors impact symptom severity, engagement, and perceived treatment effectiveness within therapy sessions? And what can we do as clinicians to attend to structural inequality while providing care to diverse youth? And I'll address these learning objectives in 2 studies, but before I do so, I just want to give you a little bit of background on this topic. So unfortunately, many adolescents who would really benefit from psychological treatment don't get the care that they need. And this graphic shows that there are really 3 key points where adolescents don't benefit from psychological services. So the first barrier to treatment is that many adolescents who need treatment might not access it, and they might not access it due to individual, interpersonal, or practical barriers. Then out of adolescents that do enroll in care might have significant problems with engagement that impacts intervention effectiveness. So many adolescents might drop out prematurely or might have trouble attending sessions, or perhaps they won't be able to complete the necessary components of the intervention. Finally, for the adolescents that do go on and actually get a full dose and complete treatment, some of them won't have sufficient symptom improvement. So there are numerous factors that impact these various gaps in between need and access. But what I think is not considered within all these junctures is how structural inequality actually impacts in access, engagement, and effectiveness of treatment. And psychologists are really interested in improving access to effective treatment across this continuum. But I think we're sort of at a loss for how best to do that in many cases. And I think it's also important to note that marginalized youth are the ones who are often the most likely to drop out and the least likely to benefit from care, even if they do receive it. I think that part of the reason why we are having trouble with addressing barriers across that continuum is that the current targets of the best high-quality research-backed psychological interventions that I'll be calling EBIs from now on, focus on the individual adolescent. So what I mean by that is that our interventions really focus on the adolescent's psychopathology. What are they coming in with? What's the presenting problem? And we might consider their race, ethnicity, age, sexual orientation, and gender identity when we deliver care. But it often doesn't really go beyond that, or at least our interventions don't have targeted information on how to go beyond that. Sometimes we do deliver interventions that account for the immediate environment that the adolescent is in. So perhaps an intervention could be delivered at a school. Maybe it's an intervention delivered in a group format with peers or addresses social functioning. Perhaps it's an intervention that's delivered at the family level. Unfortunately, there are numerous other influences on adolescent psychopathology that are largely ignored by evidence-based interventions. And I won't go into this model in a lot of detail. I'm sure that many of you are familiar with it. This is a model that was first proposed by Bronfenbrenner in the 70s. It's sociological systems theory. And essentially the idea here is that an adolescent's psychopathology or their development, their presentation, isn't just a function of the adolescent. It's a function of several overlapping environments that the adolescent is encased in that all mutually exert influence on one another. So what our EBIs ignore are these layers that are a little bit out of where the adolescent is. And these layers often include structural inequality. So if we think about the exosystem or community level as things like community poverty, community safety or violence, local politics, access to social services. If we zoom out a bit more, we can think about cultural ideologies like racism, sexism, homophobia, national laws. And if we zoom even further out, an adolescent is encased in a specific time and historical period that does impact their presentation. So then the question is, how can we actually consider structural inequality in treatment? This is really the focus of my research and what I'm most passionate about in psychology, and it's the topic of my dissertation. So I want to present you with some research that I've conducted where I've tried to begin to address this topic. Of course, this topic is incredibly broad and I've only just scratched the surface. But I want to present two studies that I've conducted where the focus really is in expanding our understanding of how to consider structural inequality in psychological treatment. And this is a mixed method approach. These two studies have very different methodologies. The first study takes a public health epidemiological approach to look at neighborhood influences on mental health treatment access. And the second study really zooms in. So here I'm looking at chronic structural stressors such as poverty, discrimination, community violence within trauma-focused therapy sessions with marginalized adolescents. And then finally, I'll talk about clinical implications. So the first study, this is the one that's kind of zoomed out, neighborhood influences on mental health service access. A bit of background here is that research on barriers to mental health service access have really focused on barriers and facilitators at the individual level. So when I say the individual level, I'm talking about things like demographic characteristics. Perhaps you've heard that racial minority adolescents are less likely to access treatment, or perhaps factors that aren't exclusive to demographics, such as maybe the cost of services or the time necessary to receive services is a barrier. However, what's left behind here is considering how our individual help-seeking behavior is actually shaped by the environment that the individual is encased in. Focusing on individual and family predictors of psychological treatment utilization really does overlook the influence of neighborhood factors that may directly influence individual help-seeking behaviors by shaping the environment that the individual is nested in. I propose that understanding how how neighborhoods influence help seeking can point us to novel interventions. I really think that the lack of attention to neighborhood level predictors of help seeking really limits our understanding of why disparities in help seeking exist, and it limits the scope of interventions we can deliver. The goal of this study was to take an epidemiological approach to tease apart the influence of individual and neighborhood factors on accessing mental health services. So I looked at variables on both the individual and the neighborhood level. The goal here is to look at the unique influence of both the individual and the neighborhoods. We can kind of control for both and tease apart what really does impact help seeking. And I think that likely both individual and neighborhood variables will impact help seeking through mutual and likely interacting pathways. On the individual level, I'll be looking at variables that have been widely addressed in the health literature as impacting care, such as depression, victimization. I'm defining that as psychological need, race, ethnicity, gender, immigrant status, and health insurance status. On the neighborhood level, I'll be looking at the provider density of how many mental health care providers are in a county, county deprivation, or the socioeconomic level of resource within a given county. And I'll be looking at county safety, which here was essentially defined as how much violence is there within this county. And I'll talk about each of these variables a bit more later on. Like I said, this was a bit of a public health approach. So I used a large nationally representative data set. I looked at the National Survey of Adolescent to Adult Health. This is a survey that I'm sure many folks are familiar with. It has been going on for quite a long time. It began in the 90s and has been longitudinal going all the way until today. The participants are now in their midlife. And I'll be looking at waves 1 and 2. The data is certainly a bit older, but these were the waves where the participants were actually adolescents. And so that's really the developmental period that I'm most interested in. The sample size that's included in my study is 9,827. There are a lot more participants in this study, but these are the ones that had sufficient data to be included in the analyses. The data for this study is publicly available, but it's restricted as well to maintain privacy of the participants, which essentially just means that I had to apply for it and ensure that the data would be stored safely. I want to tell you a bit about my analytical approach. And the model on the right, it looks a bit complicated, but I will break it down. So again, the goal here is to look at how neighborhood level factors, so county deprivation, county violence, county provider density, moderates the relationship between psychological need and service use. So psychological need, those are the variables on the left here, depression and victimization. The way that I'm conceptualizing this is that ideally depressed adolescents who are depressed or who have undergone some level of victimization are going to need to access psychological services. So hopefully those psychological need predictors would be related to service utilization, that adolescents who need services go on to access them. What I'm proposing here is that these county level or neighborhood characteristics, sorry, I just saw something in the chat. Okay. So at the county level, the neighborhood characteristics are going to moderate or be the mechanisms that are saying how strong the relationship is between psychological need and service utilization. So these are being conceptualized, you can think of it as barriers or facilitators to whether kids with high need impact service utilization. I'm also looking at how these county level predictors uniquely impact service utilization. So even if they're not mechanisms of this relationship, do they impact service utilization on their own? And then on the bottom of this model, you have the individual level characteristics that I'm controlling for. I included these covariates based on the fact that these have been identified as the basis of disparities in access within a wealth of literature. And the question sort of is, if we account for these individual level characteristics that impact access, does the neighborhood matter? This is really a method of having more statistical control to make sure that I'm really being conservative in looking at these neighborhood effects. The approach that I utilized was multi-level logistic regression. What that means is that the adolescents are nested within their counties so that we're controlling for differences in neighborhoods. And the outcome is service utilization. Did they utilize services or not? So it's a binary outcome, which is why it's a logistic regression. And I'll be looking at cross-level interactions. That's how I'm testing this moderation. And I hypothesize that individual and neighborhood variables will both be significant predictors of psychological service utilization. And I hypothesize that neighborhood variables will significantly moderate the relationship between psychological need and service utilization, such that adolescents with high need and high levels of neighborhood barriers will be less likely to utilize psychological services as compared to those with high need but low levels of neighborhood barriers. And I'll run through some of the variables that you have a clear understanding of what I'm really looking at here. So again, I looked at wave 1 and wave 2. I was looking at how variables at wave 1, which was delivered a year before wave 2, predicted access in wave 2. So we have that, that variable of time to look at. So the dependent variable measured at wave 2 is mental health service use. Adolescents were asked, in the past year, have you received psychological or emotional counseling? As we see in my sample, not that many adolescents did comparatively. 931 did receive services, 8,896 did not receive services. And then I want to highlight my focal predictors. So those were on the left side of my model. These are the variables that define psychological need in my analysis. There's two variables. Variable 1 is depression. This is measured by the Center for Epidemiological Studies Depression Scale, the CESD, a very widely used measure within the public health literature. The outcome of this is a continuous score of depression symptoms with greater scores indicating greater levels of depression. The mean here was 11.5 with a standard deviation of 7.61. And then victimization. I define this as, was the adolescent exposed to physical violence within the last year? This was rated by self-report. Adolescents were asked if they had been exposed to various different kinds of physical violence, including in their neighborhood or at home or at school. And if they said yes, they were coded as yes, they had experienced violence. And 4,246 adolescents did experience violence in the last year. It's almost half of the sample, so it is quite pervasive. I do want to note that this variable of victimization is, it's not complete, right? There are many other ways to be victimized, but beyond physical violence, but this was sort of the best approximation that I had within this data set. Now, I want to tell you a bit about how I identified these neighborhood moderators. So the neighborhood moderators, or the neighborhood sort of barriers I'm hypothesizing, so remember there were 3 of them. The first one was county deprivation. This was measured at wave 1. I constructed this variable of county deprivation using a principal component analysis on several items within a contextual data file in the adolescent health data sets. So a PCA, or principal component analysis, is a method that's widely used in the public health literature, especially not so much in clinical psychology. And it's used to decrease the number of variables that are included in a model without sacrificing the amount of variability explained by the variables by creating what's known as a principal component. So the goal here is to explain a high amount of variance by the smallest amount of components. County deprivation essentially is a variable describing the socioeconomic status of a county. And this is a complex construct, it's multidimensional. So using just one variable to summarize the socioeconomic status of a county really isn't recommended. Rather, neighborhood deprivation is a more nuanced representation of the level of opportunity and the social conditions of a neighborhood. And this is a variable that's been constructed a lot in other studies, just hasn't been used quite as much in clinical psych. So county deprivation consisted of variables related to education, poverty, and employment. And remember, they're summed up as one variable. The next county moderator was county violence. This was again constructed by a principal component analysis, but this time it was in county crime statistics. So here I looked at the total crime rate, the violent crime rate, the number of juvenile arrests, and the number of adult arrests. Again, this isn't really the best way and the most ideal way to fully encompass county violence, but it's the best we had in this data set. And one component emerged this, so just one score. Neighborhood moderators, the last one is provider density. This is constructed a bit more simply. This is just the mean score of child psychology physicians, psychiatry physicians, and psychiatry specialist physicians providing patient care in a county. Again, there are a lot of other places where adolescents get care, but this was what we had available to us. And these are the individual covariates. I won't go into them too much, but most of these were, or all of them rather, were binary variables rated by self-report by the adolescents. So gender was male or female. Health insurance was were they insured or not. Race was did they identify as white or racial minority. Ethnicity was did they identify as Hispanic or not Hispanic. And immigration status was were they born in the US or not. So now the results of my analyses, and I apologize, there's going to be a lot of numbers here, but I'll try to break it down. So first, if we look at my full results, we see that there is a significant interaction term between depression and provider density. And this was, again, a multi-level logistic regression. So here we see that there's a significant interaction, which means that we should look at this interaction effect first. The way that I looked at it was looking at fixed simple effects, the fixed simple effect of depression moderated by county provider density. So how does depression predict access at different levels of provider density? So here, if we look at the results, we see that depression is a significant predictor of access at low, medium, and high provider density, but we see that the effect gets larger for depression as provider density gets larger as well. So youth who have higher depression scores have greater odds of utilizing mental health services if there are more mental health care providers in their county. Then I want to highlight the fixed domain effects at the county level. Here there was a significant main effect, so a significant direct effect of county deprivation on help seeking. So adolescents who lived in counties with greater deprivation have lower odds of accessing treatment. So greater deprivation is sort of a barrier to accessing care. Adolescents who live in counties with a greater average depression score have greater odds of accessing treatment. Looking at depression at the county level is sort of saying statistically necessary in multi-level modeling. I won't go into that in too much detail. I think county deprivation is really what we want to focus on here. And then if we look at the fixed effects on the individual level, these are the variables that I was really trying to control for. So adolescents who were US born, female, and white had greater odds of accessing treatment, while uninsured adolescents had lower odds of accessing treatment. And then the final variable of psychological need, victimization, was such, the effect was significant such that adolescents who experienced victimization had greater odds of accessing care. So what does this really mean? I know that was a lot of results. So essentially, provider density was the only significant moderator of the relationship between psychological need and service use. Youth with high psychological need who lived in counties with more mental health providers are more likely to access services than youth with similar need who live in counties with less providers. This is consistent with research that suggests that limited availability of services is a key barrier to help seeking. That makes sense. Simultaneously, we found out that adolescents who live in counties with greater socioeconomic deprivation were less likely to access psychological services. Notably, this is controlling for all the other factors in the model. So if we hold their identity study, if we hold their county study, just deprivation on its own is a significant predictor of help seeking. Simultaneously, there's research out there that indicates that deprivation is also related to greater risk for psychological concerns. So we can think about this as adolescents who live in areas with high deprivation are at sort of double risk or double jeopardy of poor psychological outcomes. They're simultaneously at higher risk of experiencing psychological concerns and at higher risk of not accessing necessary care. The mechanisms that connect neighborhood deprivation and help seeking are not really well understood. Some folks have proposed that living in a community with greater deprivation leads to greater hopelessness and powerlessness, making people less likely to engage in help seeking. It's also possible that living in an area with more deprivation renders adolescents more likely to encounter structural barriers to care, like lack of financial resources or unpredictable work schedules, which have all been documented to be related to lower rates of help seeking. Again, there are some limitations here, chiefly that the data was older and that this is an imprecise sort of measurement of neighborhood level factors. And I want to highlight the clinical implications here. And I think they're really twofold. We have implications on the policy level and on the clinical level. Before I go into them, I just really want to highlight that I really learned that utilizing research methods common in the public health field, like examining epidemiological data or looking at neighborhood influences on health, increases our scope of understanding of the various influences on psychological help seeking and opens the door for clinical psychologists and psychiatrists to more effectively create interventions to promote access. On the policy level, I think that our data points to the fact that greater funding for greater levels of psychological services, particularly in areas with a low amount of providers, could promote access to care. Funding for poverty alleviation initiatives also holds great promise in decreasing neighborhood deprivation and therefore increasing help seeking. I think the question that we could all ask ourselves is how can mental health care professionals become stakeholders in making these policy decisions? And also notably, I want to say when I talk about poverty alleviation initiatives, there's numerous ideas that folks have thrown out, such as implementing a universal basic income program, rent control in a neighborhood, or increasing access to vocational training. Clinical interventions that we could all implement in our clinical practice could be things like deciding where new services should be concentrated. If we're thinking about where to target a new clinic opening, for example, based on this research, it should be in areas of more deprivation and less provider density. And I think this really points to the fact that it's important to assess neighborhood context early in treatment. These neighborhood variables matter in terms of whether adolescents go on to access and benefit from care. I also quickly just wanted to highlight a poverty alleviation initiative that's happening here in the County of Los Angeles. I have a QR code here. Feel free to scan it if you're interested. The county is doing a lot to try to alleviate poverty, and this link here has a lot of excellent resources that can be shared with patients and families for available resources they can take part in to help with those who are exposed to poverty. Now my second study, this is the one that's really zoomed in. So chronic structural stressors and trauma-focused therapy sessions with marginalized adolescents. Let me give you a little bit of an introduction here. So this study focused on PTSD specifically. That is one of my clinical areas of interest, and a lot of my research focuses on improving PTSD interventions. I was interested in examining chronic structural stressors in therapy sessions because exposure to chronic structural stressors, things like poverty, community violence, and discrimination, has been well documented to exacerbate PTSD symptoms. Simultaneously, PTSD evidence-based interventions seldom include any sort of concrete guidance on how to target chronic structural stressors in care. And there's really little known about how chronic structural stressors actually come up in therapy sessions and if they do at all. So my goal here was to use qualitative analysis of taped therapy sessions to investigate how diverse, low-income adolescents talk about chronic structural stressors during short-term PTSD therapy sessions. Again, nobody really knows how these chronic stressors emerge in treatment. And so this was hoping to answer that question through 3 specific aims. The first one was, how often do adolescents disclose chronic structural stressors in therapy? Do these stressors even come up? The next aim was, if they do, what types of chronic structural stressors are disclosed? The final aim is, what is the context and the content of these disclosures if they do occur? Notably, the study took place in an intervention that didn't directly assess or talk about chronic structural stressors, so it's similar to many interventions that we deliver. So this was really asking organically with diverse adolescents, how often does this material emerge? A little bit about the design. This was data from a pragmatic feasibility trial of the primary care intervention for PTSD called PSIP. It was delivered at Boston Medical Center. PSIP is a 3-session intervention to be delivered in primary care to target PTSD. It's the first intervention of its kind that's been developed for adolescents in particular. The focus here is on psychoeducation, skill building, linkage to further care, and reducing stigma and help seeking. And it was delivered in Boston Medical Center, which, if you're not familiar, is a large safety net hospital in Boston, primarily serves minority status individuals, with 72% of patients receiving care in the center and in this hospital being funded by public insurance, such as Medicaid. I qualitatively analyzed taped therapy sessions, which I'll go over those methods in just a bit. And I want to tell you a little bit about these participants. So we had significant dropout in the study. So this really shows that engagement is fraught with minority status adolescents receiving care. As we do know, there are 13 participants in total, but only half of them actually completed the 3 sessions of the intervention. 29% dropped out after 2 sessions, and 21% dropped out after 1 session. So significant difficulty with engagement. In total, there were 25 recorded and transcribed therapy sessions. There were a few that were lost due to the clinician and not recording the session or forgetting to give the recording to the research team. But there were 25 that were recorded, and the clinicians here were ones that were already embedded within Boston Medical Center. They were licensed clinical social workers who were delivering care in the adolescent medicine clinic at Boston Medical Center. Bit more information about the sample. So the adolescents here were quite diverse in terms of race, ethnicity, gender identity, and sexual minority status. Although the sample was small, it was quite diverse, so a great sample to look at contextual factors. The average age here was 19. There were some that were younger, a couple that were older, and again, this is an adolescent medicine clinic. So this was the adolescent to young adult range. I want to talk a bit about my qualitative analysis so that you have an idea of what I did. So number 1 was that I developed a preliminary code book based on my research question and a literature review. Then I worked with a team of research assistants to conduct inductive coding. So we looked at a few transcripts and edited the code book as new features of the data emerged. Then we all worked together to apply our finalized code book to all of the transcripts. Each transcript was double coded. There's a team of 4 undergraduate RAs. And after double coding, our agreement between raters was quite high. It was 0.86. But the coding was complex. We decided ultimately to go over each transcript together and settle any disagreements by consensus. And finally, I worked with 2 additional research assistants, or not additional, but 2 out of the 4 research assistants to identify, define, and name the themes that emerged from coding. Now the results. The first question was, how often do adolescents disclose chronic structural stressors in therapy? Does this really come up in therapy sessions? So the answer is it does. The structural stressors code was applied at least once in at least one therapy session for 10 out of 13 participants. So 77% of the sample did talk about chronic structural stressors during their care. The next question was, what types of chronic structural stressors are disclosed? There was really a range here. So stressors included lower socioeconomic status, discrimination, lack of community resources, tenuous living situations, family incarceration, unequal policing, and the presence of community violence. Interestingly, these stressors were pretty rarely linked to the participant's identity. They often just spoke about the stressor and didn't explicitly say that it affected them based on their minority status. And if participants did talk about the presence of a stressor related to their identity, it was often because the salience of that stressor was magnified due to one or more minoritized identity statuses of that participant. So we have an example quote here. The participant says, straight guys and gay guys, we have an interesting relationship, all of them. My relationships with a lot of straight men, I tend to walk on eggshells around them because you don't want to do something to keep them out. You don't want to do something to push them away. So here, this participant is talking about social isolation and feeling like he has to walk on eggshells. And as we can see, there is a level of homophobia implied here, but it's not explicitly stated. There was some onus on the therapist to really understand what the participant was referring to. Finally, what was the context and the content of these disclosures? Three key patterns emerge, and I'll go through each one. First, structural stressors exacerbated psychological distress. They also impacted treatment engagement, and they decreased intervention effectiveness and acceptability. The first theme was that structural stressors exacerbated psychological distress. The stressors that participants identified as exacerbating their distress were socioeconomic status, incarceration, community violence, tenuous living situations. Notably, participants also often describe pretty complex relationships between different kinds of structural stressors they experienced and their psychological symptoms. Here we have one participant who is really explicitly stating that the structural stress of the threat of community violence in her neighborhood has exacerbated her PTSD symptoms and made her more fearful. When I go outside, especially when I'm walking to the train, I feel like I have to be on the phone with someone. Like, I can't just walk outside to the train because I feel like something is going to happen. There's a lot of violence in my neighborhood. So I always feel the need, I have to be on the phone. Another example of how psychological stressors really magnified distress was that they exacerbated participants' sense of alienation from their community. For example, this participant described how the disparity between her socioeconomic status and that of her classmates has led to interpersonal problems and a lack of perceived community and understanding. She says, I just feel like my classmates don't understand me. They don't get it. My roommate, she's privileged, and I just go to school and I go to work. I'm really not, they don't understand. She's like, why are you working so much? The next theme was that structural stressors impacted treatment engagement. Notably here, the stressors that most often impacted engagement were socioeconomic stressors, so being of a lower socioeconomic status. This really impacted participants' ability to engage in the requirements of the piece of intervention. Again, the individuals in this hospital were largely below the poverty line and faced a greater magnitude of uncertainty regarding their income and access to necessary resources than participants with more socioeconomic resources. Uncertainty regarding work schedules is a particular barrier for participants in scheduling therapy sessions in advance and completing homework. So here we have a participant who reports that because they had to work numerous hours each week to make ends meet, they were overall exhausted and they had limited time to complete therapy homework assignments. When I'm not working, I'm sleeping. And when I'm not sleeping, I'm working. So that 30 minutes a day or even 25 minutes a day can be very hard to find. And finally, structural stressors impacted intervention effectiveness and acceptability. This was a theme that only emerged for one of our participants, but it was quite salient for her. So she described how structural stressors impacted her perception of the intervention effectiveness and therefore her willingness to be engaged in therapy. And ultimately, this participant did drop out after 2 therapy sessions. A little bit of background on her that I think will add some context to the quotes was that this was a transgender woman of color who was involved in the foster care system. She had undergone numerous traumatic events and faced chronic discrimination that rendered her more likely to become re-traumatized. For example, despite being a transgender woman, she was placed in a foster home for males. And she explicitly talked about how the intervention components were not compatible with the level of chronic structural stressors that she faced, particularly considering her continued exposure to discrimination and her perception of her lack of agency in ensuring her future safety. Here there's a quote where she explicitly describes how the therapy skills, including relaxation and psychoeducation introduced in the intervention, were not suitable for targeting her distress, because she continues to face numerous stressors. So she explains, I was forced to become an adult before I was ready. I had to take care of myself. I had to feed myself. I went to a place where I was different. I knew I was different. And when I came out as different, I was abandoned again. I lived on the streets. I am homeless. It's like, there's a whole bunch of things that I could have control over if I have the ability, but I don't. I have to look my trauma in the face every single day, the lack of control, the lack of power. And so when you have to look at your trauma every day, how do you cope with it? You can't. Another powerful quote of this participant talking about how the intervention was not effective or acceptable to her. So she talked about how the messages that she has received in treatment regarding feeling safe after trauma exposure, which we know is a key part of trauma-focused care, was incompatible with the dangers that she was exposed to, given her identity as a transgender woman of color. She says, I'm scared of everything, and it's because I have to be, because I don't have the luxury of nothing bad is going to happen, because being who I am means everything bad can happen. I could die leaving here. Those things sit with me, and although I don't think about them because that's way too depressing, I don't have the luxury to not think about them also. The therapist says, I hear what you're saying. The world's not a safe place for you. So to try to teach yourself or tell yourself that it is safe is potentially really dangerous. To sum things up here, I learned through this study that structural stressors do often emerge in therapy sessions with minority status participants, and they often exert mutual influence on one another. Again, stressors came up with 77% of participants, even in such a small trial for an intervention that was very brief in nature. And again, a discussion of the stressors was not a part of the intervention. The participants just brought these up on their own. The stressors were related to psychological distress, treatment engagement, effectiveness, and acceptability. And although the sample size of this study was small, the frequency at which participants disclosed the stressors within this brief intervention suggests to me that similar disclosures are occurring within many therapy sessions with marginalized clients. This result is really striking given the overall lack of guidance in many mainstream evidence-based interventions regarding how to acknowledge structural stressors in treatment or actually address their impact on the client's symptomatology and treatment engagement. These findings are also in line with existing research that exposure to chronic structural stressors may exacerbate psychological symptoms even when individuals receive therapy. And the results also highlight that individuals receiving therapy services are explicitly aware of the impact of chronic structural stressors on their symptoms. So again, together, this really, really highlights the need for incorporating guidelines regarding the discussion and consideration of structural stressors within psychological interventions and how this content does in fact maintain psychological distress. Notably, the participants in this study were adolescents. That's an age group that often doesn't have a lot of autonomy or control over their environment. And their marginalized status also rendered them more likely to experience chronic structural stressors, and that further likely exacerbated their feelings of lack of autonomy and control. Lack of autonomy and control in decision-making, I think, might be some of the primary mechanisms through which chronic structural stressors decrease PTSD treatment effectiveness and acceptability for marginalized groups. I say this because the goal of PTSD treatment is to really increase the patient's sense of safety and control over their environment after experiencing a traumatic event, wherein their sense of safety and control is completely taken away. But facing these stressors really limits folks' ability to exert control over their environment in service of building that sense of personal safety and power. So existing EBIs, don't provide clinical guidance on this, and I think we really need to deal with this reality. So what are the clinical implications of this study in particular? I think one takeaway is that there's no one-size-fits-all solution. We saw the different kinds of stressors impacted different participants in different ways. Um, First, I think, again, EBIs need some level of guidance on how to consider structural stressors when delivering care. I think that for participants who are having difficulty with engagement due to socioeconomic stressors, accessibility promotion interventions can be powerful. This can be things like making services free, providing free transportation to treatment, or having really flexible scheduling with treatment. And I think that adapting interventions might be necessary for some patients, so maybe additional guidance is not enough. I think that this really could come in handy for the one patient that we had who said that components of the intervention were incompatible with her symptom presentation and the structural stressors she faced. So perhaps adapting EBIs to directly address the influence of structural stressors within PTSD treatment could be necessary for participants like this, particularly if participants are dealing with the influence of discrimination, and when delivering care to adolescents with intersecting minority identities. I think this is interesting, particularly given conflicting research evidence regarding whether cultural adaptations to evidence-based treatments are more efficacious than standard EBIs. Maybe the answer here is that the efficaciousness of culturally adapted interventions is moderated by the unique experiences like chronic discrimination, and associated treatment needs of the individuals. Works for some folks, but not others. I finally wanted to just have one slide that highlights some of the takeaway points here for clinical implications. Structural inequality requires structural solutions. So just changing the way that we do things as individual clinicians or researchers is not going to be enough. The interventions have to happen on the policy, intervention development, hospital system, and individual level. We need to go beyond the therapy room to impart change. I think if us as clinicians and researchers shift our focus from the care of a single client to the care of the community at large, the impact on the lives of our marginalized patient population is likely to be so much more pronounced. On the policy level, I think increasing funding for mental health services and poverty alleviation would be a powerful intervention. I'm also curious about how we can become better advocates for our patients at the policy level, perhaps lobbying for more equitable distribution of resources within communities, like advocating for affordable housing. On the intervention development level, we do need that concrete guidance on how to target structural stressors in each and every evidence-based intervention. Perhaps also changing the format of interventions to deliver them more flexibly. We saw that even in a brief intervention, there were significant barriers to engagement. Maybe we could think about interventions delivered through novel internet formats, or perhaps single session interventions embedded in health systems. And if we think about our hospital system, there's things we could do on this level here. For example, accepting public insurance in all parts of the hospital system to limit barriers to care, promoting accessibility, perhaps reaching out to communities that aren't generally accessing our services, or putting new branches of the hospital in areas with lower levels of access. And more flexibility in scheduling. I know that often our clinics are overburdened, overtaxed, and patients are given just one time slot that they have to fit into their schedule for a week. Perhaps it can be a bit more flexible and give them a few additional options. What can we do as individual clinicians? I think first and foremost, increase training and structural inequalities so that folks are well aware of how these stressors impact the patients we treat. Assessing structural stressors at the start of treatment so that they can inform a strong case conceptualization for the client and really point you to possible points of intervention. Engaging in case management when appropriate to help patients access resources that they need, and engaging in advocacy with and for the patients that we work with, both at the individual level, advocating for the patient, and thinking about how we can advocate at the policy level. Thank you, everyone. I really appreciate you attending this presentation. I will stop sharing my screen in a second to open it up to questions, but I've also included my email in case anyone would like to contact me. There will be publications coming out summarizing these studies in more detail, so if you'd like a copy of those, I'm happy to send it your way. So just go ahead and send me an email. Thank you.
Great work, Gia. Very compelling and interesting studies that you presented on. Everyone, please add your questions either to the chat or the Q&A box function. But in the meantime, Gia, there was a question about your first study where you looked at neighborhood effects and kind of used counties as a proxy to estimate neighborhood level factors. And the question is, do you think that counties are the best proxy or approximation for neighborhood level factors? Or is there a different way to look at these factors?
Honestly, I don't think they are. I think that counties are a bit too zoomed out. Even if we think about LA County, there are so many different neighborhoods here, and there's going to be a really different experience of an adolescent who's living in Beverly Hills versus somewhere on the east side of LA or in South Central Los Angeles. So ideally, the best way to look at neighborhoods would be to look at census tracts, which I did try to do within this study. Unfortunately, all the variables of interest were not available at the census tract level. I did look at a census tract level socioeconomic deprivation, and the effect was the same at the census tract level. So I do think that this would hold up. But if we are able to be a bit more precise in measuring effects at a more kind of granular neighborhood level, I think that that would really point to more precise effects and also point to better ideas for intervention.
Okay. And I guess a follow-up to that question, Gia, do you think even if we were to use census tract data, do you think that there are some variables that are not really necessarily captured in census tract data that you think would be very important for the work that you do?
Yeah, I think that there certainly are. And I think that that was really highlighted through some of my presentation. The statistics that we gather are pretty limited in assessing the constructs of interest. For example, if we think about county violence or county safety, the statistics that we usually have are like crime statistics, and a lot of crime isn't reported. Neighborhoods are also over policed, and so I'm kind of, questioning, is this what we're really measuring? I don't know if there's a great way to measure some of these variables beyond self-report of doing a survey of folks in a community, but I do think we have a way to go to really understand how neighborhoods influence health.
Yeah, great. And there's another question about your first study, and it's regarding neighborhood level factors, and if you think that they differentially impact, structurally marginalized youth's ability to access care versus youth that may have more access or may have more privilege.
Okay, I think that's a really good question, and I think something to consider, given that we know that youth with marginalized identities do have a harder time with accessing services. And this is something that I actually tried to look at in the data as well. So I looked at whether the structural or the neighborhood level variables moderated the relationship between identity predicting access, and they actually really didn't, which I thought was surprising. So it seems like structural inequality at the neighborhood level kind of impacts everybody equally, but it's another case where youth might be sort of at double jeopardy, right? They're dealing with lower resources due to their identity status, and we think about structural ideas like racism or sexism, and then in addition, they're also contending with living in neighborhoods with less resources. And I think it's important to note that minority status youth are also a lot more likely to live in neighborhoods with less resources. So I think we're also getting a little bit of that effect there.
Yeah. And it was really interesting how identity did come up, right, organically in the therapy room or in the sessions. And I'm curious to hear if any interventions that you've come across have actually been adapted to really address these structural stressors that you're talking about.
Yeah, I think that there have been, and I think there's more and more research coming out for how interventions can be adapted. I think that for PTSD, which is my one of my areas of interest, an intervention comes to mind where they actually adapted TFCBT to be for youth exposed to racial trauma. So that's a really excellent intervention. But I think what the issue is that the interventions have been adapted for specialty clinicians delivering care in really specialized clinics who already have a lot of understanding about structural inequality. And what I think we really need is more widespread awareness and access. And this should really be a component of every intervention if we want to be successful in treating diverse youth.
Yeah. Yeah. And I think a lot of the trainees in our department, they're always very eager to learn, like, what can we do, at the individual level. You've really highlighted like the structural things that we can do to advance health equity. But I'm wondering if you can wrap up and share with us your thoughts on what can we do at the individual level as clinicians to really advocate or to address these structural issues in our work and what we do daily.
I think that one of the most powerful interventions that a clinician can do is really looking at your patient as a whole patient, taking their neighborhood into account, taking the various levels of privilege they have or disadvantage that they have, and seeing what need is there. And then leveraging our place as clinical psychologists or psychiatrists and advocating for that patient. One case comes to mind for me that I think sort of illustrates this point. This is a patient I saw in the inpatient service, and it was somebody who was going back to a school that wasn't meeting her needs, and the family didn't really have the resources to advocate for what was necessary. And so rather than sort of taking a step back and saying, okay, like here's how you deal with, and this is what you do, I actually helped work with the family and I talked to the school directly to advocate for the patient, knowing that they're likely going to listen to a psychologist when they might try to brush off a family who isn't as well resourced. So I think using your voice to try to limit the impact of structural inequality when possible for your patients.
Yes, using your own power, right? That we have by being in such a large institution like UCLA.
Mhm.
Great. Well, wonderful work, Gia. If you could share your email in the chat as well, I'm sure people would love to follow up with you.
Yes.
Thank you for doing the work that you do. It's so important. And I'm excited to see where you take it from here.
Thank you, and thanks everyone.
Thank you, everyone.